So now we are having the final session at the EBC meeting, and please take a seat so we can get started. And maybe you can get prepared for the final dinner. I have my co-chair, Stankovic, here, and we have a panel of Christian Wachtell, Yutaka Hikichi from Japan, Alexandru Achim, Lilian Grigorian. Should she be here? Yeah. Joby Thomas and Ahmed, Ashraf, Eissa. Please come and join us here in the panel, and let's have the first talk. It's a recorded talk from Ankush Gupta. You saw before that he was ready in the recorded case. Thank you.
Dear Chairman, thank you for the invitation. The title for my presentation is IKIS Left Main Trial Protocol. First of all, I would like to thank all the investigators of IKIS Left Main Trial who are putting a great effort for this trial. For simple distal left main bifurcation disease, provision stent strategy is preferred. Kissing balloon inflation after provision stent strategy is intended to clear the stent studs across side branch ostium. There is no definitive evidence either supporting or refuting the routine use of KBI in provisional stent strategy for left main bifurcation angioplasty. The study aims to assess the impact of routine KBI in patients undergoing left main bifurcation angioplasty using provisional stent strategy. This is a prospective single-blind multicenter randomized control trial conducted at 20 centers across India. Patients with simple distal left main bifurcation disease planned for left main duality or LCX crossover stenting using a provisional approach are enrolled. All enrolled patients are randomized to either KBI or non-KBI group using a computer-based randomization tool. These are inclusion and exclusion criteria for patients with complex left main bifurcation disease, patients with history of CABG, PCI to left main, or patients undergoing primary PCI for STEMI are excluded. For sample size calculation, we used the reported rate of side branch restenosis in Nordic Baltic study, and it came out to be 630. This is the workflow of our trial. A total of 630 patients with simple left main bifurcation disease planned for provisional stent strategy will be randomized to either KBI or non-KBI group. All patients will undergo OCT-guided or IVUS-guided left main bifurcation angioplasty. And once the pot is done in KBI group, the side branch will be rewired through distal stent struts, and it will be preferably confirmed using imaging either IVUS or OCT. And after that, KBI will be done. For the side branch, the balloon size will be 0.5 smaller than the distal reference diameter at 15 mm from side branch ostium, and after KBI, both main branch and side branch will be imaged. In non-KBI group, after pot, only main branch will be imaged, and a note will be made of whether we are leaving a link-free type of carina or link type of carina, or if we are using IVUS, we'll be using L mode to document number of the amount of stent studs across side branch ostium. All the patients will be followed up clinically for 12 months, and a plan angiogram will be done at the end of it. The primary endpoint of the study is significant increase in angiographic side branch restenosis at the end of 1 year, and the secondary endpoint is MACE and stent thrombosis, and the MACE is a composite of cardiac death, non-fatal MI, and target lesion revascularization. At the end of 12 months, angiographic analysis will be done at Core Lab, Madras Medical Mission, Chennai, India. This trial is registered with CTRI. This trial has got some limitation that this is not statistically powered to detect differences in the clinical outcome between KBI and non-KBI strategies. The choice of DES and DAPT is left to the operator's discretion, which may introduce variability and impact the trial outcome. However, angiographic restenosis remains a clinically meaningful endpoint and will provide a valuable insight into the optimal intervention strategy. So let me show you a case that was randomized to KBI arm. So this is the case that was planned for left main to LAD, stenting with the provisional stent strategy. This is the OCT pullback of LAD, and this is the OCT pullback of LCX. The LCX ostium, the area is 4.54 and 15 mm from LCX ostium. The size of LCX is 3.07. So for KBI, the size of side branch balloon will be 0.5 smaller than this, is that is 2.5, and after the left main LED stent is placed, this is the pot being done, and this is the most crucial step of provisional stent strategy, and we recommend the use of two caudal views to confirm the position of distal marker of pot balloon, and after pot is done, the side branch is rewired through distal stent studs, and it is confirmed using imaging, and in this case we found that our wire has gone through the proximal stent stud, which can be seen in L mode, B mode, and 3D reconstruction. And on third attempt, we were successful in crossing the side branch through distal stent studs. And after that, KBI was done. And after report, both side branch and main branch was imaged. And this is the pullback of the LCX. And we found that there was no dissection of the side branch ostium, and the side branch ostium was scaffolded by some of the stent studs. This is the main branch pullback, hardly any stent studs across side branch ostium there with the reasonably good areas. This was the final angiographic result, and this is how we are using IVUS also to find our position of side wire crossing through side branch ostium. Till now, we have enrolled 56% of our patients in this trial without any difference in the adverse event, and these are the areas that we have achieved in both KBI and non-KBI group. Thank you very much.
Comments or questions also from the audience or from our panel? Criticisms? Yeah, of course.
No, I think I just wanted to appreciate the investigation that they chose the primary endpoint to be more than 50% stenosis at the level of the OSLCX, and they didn't choose a clinical outcome like MACE, because we cannot prove if we do or we do not do kissing balloon inflation, we cannot prove a benefit in MACE. And I believe just that they designed the trial well.
Yes, side branch opening is important. We all understand. However, same as the main vessel stent deformation, to reduce the deformation is very important. So we have to carefully to use in the if you perform the KBI, be careful. KBI is very important. I think so.
Do you think? Manuel, sorry.
Yes, I didn't understand very good the protocol. The patient is randomized if the circumflex is free of stenosis after the main vessel stent implantation for the left main to the LAD or not?
No.
But
It's crossover and then
after crossover, you have two possibilities: compromise of the circumflex or not. All these patients are randomized, or only those without a significant lesion at the circumflex?
I didn't get this point.
Yeah.
I think if there's an indication for doing a KISS at the index, they should not be randomized. It should be when you are in doubt. That means there should be no flow limitation in the circ, and then you can randomize, because you cannot randomize to doing nothing if you know it's indicated. Otherwise, there's a problem with the protocol.
Yeah. Yeah. No.
So anyone who wanted to have some physiology as an endpoint.
But the doubt is when you implant the stent across the bifurcation and you have not angiographic stenosis or significant angiographic stenosis. This is the an old discussion in the EBC. So open or not open the strat. But if you have a lesion, I think it's not.
I think Evald is right. If there is severe compromise, of course, it's not subject to randomize.
Yeah.
I don't know if Dr. Dugal or anybody knows the protocol better.
Two-stent strategy, that patient is not taken into consideration if you have compromised the circ.
So I think it's only in case that you don't have compromise, whether you should remove metal from the ostium or not.
So it must be the balance between doing some damage with the balloon in the circ ostium. So I think this should be a very careful KISS where you only move the metal and not, because you could also with the KISS induce something.
Yeah, that is why 0.5 less than the diameter, which is measured by intravascular ultrasound or OCT, is taken to do a kiss, not the less than 0.5.
Yeah, but,
So
but stepping down in size, you're not moving the metal maybe enough to the outer curve. So another strategy could be just to have the balloon tip in and do a good kiss in.
Yeah.
Proper diameter.
Yeah, just move the metal and not traumatize the circosteum.
If there are, yeah, I think this was just informative because we like the study that will finally test whether or not we should perform kissing in crossover. Actually, to build on the available evidence which goes in both directions. So let's now go to presentations. I would like to invite Dr. Murasato. Efficacy of routine intracoronary imaging guided left main PCI, 1 and 3 year clinical outcome from multicenter Japanese registry.
Thank you, Goran. It is great honor to be here. My topic is the efficacy of routine intracoronary imaging guided LM PCI clinical outcome from multicenter Japanese registry. A new guideline strongly recommended the intracoronary imaging guidance in left main PCI as class 1A. However, there is a clinical question. Large registry studies used intracoronary imaging guidance in selected complex PCI cases. Previous left main PCI randomized control trial excluded ACS with hemodynamic collapse. Therefore, there are two unanswered questions in the real world. Does routine imaging guidance benefit all left main PCI cases? Is it effective in high-risk left main ACS cases? So we conducted a study to investigate the clinical outcome of left main PCI in a cohort of Japanese National Hospital Organization where intracoronary imaging guidance has been routinely performed. The total of the back, please. It's okay. It's okay. So the study is a multicenter retrospective observational registry study. A total of 806 consecutive patients who underwent PCI for unprotected de novo left main lesion with drug-eluting stent implantation in 19 hospitals. Study period from 2016 to 2020. Of the enrolled patient out of criteria and incomplete follow-up at 1 year, these cases were excluded. Finally, 743 patients were analyzed. Primary endpoints are major adverse cardiovascular and cerebrovascular event, MCCE, defined as composite endpoints following at 1 year follow-up, all-cause death, cerebral vascular disorder, clinical-driven revascularization, myocardial infarction. Secondary endpoint the risk factors of 1 year MSCE. Because of the consecutive enrollment, this cohort has a higher prevalence acute coronary syndrome, around 31%. Cardiogenic shock and cardiopulmonary arrest also included around 8%. Therefore, CCS classification is relatively higher, more than class 3, account for 40%. In terms of region background, bifurcation region is presented to the 78%. True bifurcation region included 35%. Medina 0X region, angiographically non-significant LM region. However, intracoronary imaging detected left main region included in 31%. In terms of PCI procedure, radial access was performed in 70%. Imaging guidance reached to 98%. And notably, two-stent is dramatically decreased to 8.8%. And compared to other left main registry study, a port was more frequently performed in 53%. Sidewind dilation in one stent was also frequently performed in 75%. Mechanical support device was also frequently used in the 16%. PCI success reached to 99%. 1 year MSCE account for the 17.5%, All-cause death, 8.9%, clinical-driven revascularization, 8.2%, myocardial infarction, and 1.9%, cerebrovascular disorder, 1.2%. Left main PCI site-related event, cardiac death, 3.4%, target region revascularization, 2.0%. This event rate is very low. And the risk factors for the 1-year MSSE, the following: 2 stent implantation, mechanical circulatory support device using, and CCS more than class 3, elevates the risk. LVEF 10% increase and radial access decrease the risk. We also harvested this 3-year follow-ups this year. We found the gradual increase of this event from 1 year to 3 years. 3-year MSSE account for 32.3%. All-cause death, 15%, clinical-driven revascularization, 15%, myocardial infarction, 3%, cerebrovascular disorder, 4.1%, cardiac death, 4.9%, target region revascularization, 4.0%. Therefore, left main PCI site-related event still keeps a low rate. We conducted subgroup analysis using the cumulative curve of 3-year MSSE by log-rank test. According to this study, the mechanical support device using CCS class 4, left main 2 stent, non-radial access, true bifurcation region, ACS, LVEF less than 40% has more risk compared to the baseline group. We also conducted a match-valid analysis to identify the risk of 3-year MSSE. We found a similar risk factor was identified as in a 1-year MACE. 2 stent implantation, MCS using, CCS class 4, LVEF less than 40% elevates the risk. Radial access decreases the risk. We also performed the subgroup analysis comparing the 241 ACS patients and the 516 non-ACS patients. In this analysis, ACS patient had more higher event rate in the 3-year MACE and all-cause death. However, after 30 days, there is a significant difference was disappeared in the MSSE rate. On the contrary, mortality rate is still high in the ACS group. Therefore, higher MACE rate in the group with ACS was mainly attributed to higher mortality within 30 days from the index PCI. On the contrary, there was no significant difference in the clinical-driven revascularization, TVR, TLR between the groups, which indicates the efficacy of the routine imaging guidance in ACS with more complex region. Ladies and gentlemen, this is my key messages. Routine imaging guidance in left main PCI promotes optimal stent placement, avoids L6 over-treatment, and improves the local efficacy. In ACS with severe left ventricular dysfunction requiring the mechanical support, mortality remains high despite imaging-guided PCI, highlighting the need for comprehensive hemodynamic and systemic management. Multiple vessel involvement requiring the 2 stent increases the revascularization risk. Careful region assessment and strategy selection are crucial. Thank you for your attention.
Thank you very much. I have a burning question about the use of POT, because you use imaging in all, but POT in only half of the cases. How can you get a good stent expansion? What technique did you use?
The kissing balloon inflation performs more frequently, 75% case. So we check routinely the stent expansion in the proximal part. If the kissing balloon inflation sufficiently expanded the proximal area, some doctor skip the POT.
You mean repot? You did not perform initial POT before kissing?
In Japan, report is not so frequently performed. So we perform the report around 20 to 30% because the imaging, we confirmed the sufficient expansion in the proximal part.
No, but 52% POT
Yes.
refers to POT before kissing.
Yes, pot and kissing. That is 53%.
Yeah, okay, a little bit lower according to expectations with image guidance. Nicholas?
Can I ask a question that is not non-related to bifurcation? We were quite intrigued by the positive impact of radial access on the clinical outcome, and it appears that first it was an independent predictor of good outcome, and it appears also that the benefit, according to your curves, were still going on after the initial procedure. How can you explain that? Is it something that is related to the profile of the patient, or how can you explain?
Yes, radial access decreases the risk of the 3MAs. According to the match biology analysis, probably radial access is likely to perform the patient without shock state. That is one reason. However, match biology analysis perform. So such kind of shock patient is equally active, the efficacy. And another efficacy is bleeding, pancreatic bleeding. So radial access decrease bleeding complication. That is an important point to the decrease risk.
I have a question. So actually 97% of imaging, it's a completely different world that even we here in Europe or Western countries are living, where the proportion of patients undergoing imaging in PCI is around 10%. So when you are saying even improved outcomes, you basically even don't have a control group, right, in your cohort. I would like to ask you, all left domain are the same? All imaging is the same based on your huge experience of using the imaging?
You mean the OCT versus IBUS?
Yeah.
Personally, I like OCT guided LM PCI because OCT can identify the guide wire recruitment point and clearly identify the stent deformation. However, in Japan, 80 to 90% perform the IBUS. In this analysis, 88% is the IBUS analysis. However, the clinical event rate is very low, especially TLR 1 year 2%, 3 year 4%. So TLR is very low. Another reason is LCX treatment. The two stent is very low, 8.8%. So we use the intracoronary imaging to avoid the two stenting. Severe dissection, without severe dissection, dissection level is mild to moderate. We leave the LCX, the long ballooning for the LCX. That is keep the low level of the two stenting. So intracoronary imaging guidance is quite different the Western consideration.
So the fact that in Europe we are using imaging in 10% of our left main does not make any sense for the future. I think that that is an important point, as well as the familiarity with the technology. And I think it's equally important that 78% of these cases were involved in the bifurcation. And that's this different validity of the imaging according to the segment can be very relevant. The last point is the value in ACS that was clearly shown in terms of a benefit in a group of patients that are very high risk in terms of outcome compared to all the others. We needed to get a little bit of more focus on imaging use in this patient, especially with the ACS patient.
Thank you very much. And now we can welcome Sanwen Tu to talk about changing the angles in the coronaries and do that influence clinical outcome. I look forward to hear about that.
Thank you, Evald. Dear Chairman, dear colleague, thanks for getting me back again. So the title of my talk is the correlation of dynamic and changing angle with the clinical outcome. So this is my disclosure. So about 8 years ago, we proposed the superficial wall stress. So nicely can be analyzed by the angiogram. So you analyze a few cardiac phase, 3D reconstruction. So you can have a beautiful picture. However, in the end, it stays in the lab because it's too complicated to be used on site. So it's difficult to guarantee that the reliability in the analysis is on site. So, but however, it's interesting to look into the component. So there are two major contributions. One is the blood pressure interacts with the wall stress, wall and also the plaque. And the other one is the cardiac motion. So the cardiac motion including stretching, bending, and twisting. So if we separate them two and can make a simplified analysis to be able to quantify these two major components. So the first one is in the radial direction, we propose the radial wall strain. The rationale can be shown in this picture. So the blood pressure is changing from systolic pressure to diastolic pressure. The change of the blood pressure interacts with the plaque composition. So if you have more vulnerable plaque, we observe that there are more deformation, and this reflects in the lumen. And the angiogram actually gives you this information, hitting information cannot be seen by the eyes because subtle change. But if you're using AI to very precisely quantify the diameter change and matching them over the cardiac cycle, then you can quantify this radial wall strain. And this has been implemented and make it easy to be used in the software, so you can have single view MIRAFA, and then you can get the color-coded radial wall strain map indicating the hotspot is there was a vulnerable lesion behind this. And this has been the first validation study showing that angio-based radial wall strain correlate with the OCT-defined vulnerable plaque. And subsequently, we analyzed the phase 3 China study population and found that in non-flow limiting vessel, as you can see, high radial wall strain has a high event rate in 1 year. So it's comparable to combined OCT-FR data set. And if you have if the vessel has normal flow and also you have low radial wall strain, you can see that the event rate was very low in 1 year. This was further confirmed in the recent data called Target AC in European population, larger study population as well. So we have 5 years high quality clinical outcome for all the non-covered vessel. As you can see that radial wall strain nicely predict the event in 5 years, especially for the non-target vessel revascularization, which can be precisely educated to specific vessel. As you can see, if low radial wall strain, the event is very low, but if you have a high radial wall strain, in 1 out of 5, you have revascularization. So I come to the other second component about the cardiac motion. About the bending, I think stretching and twisting is very difficult to quantify reliably, but the bending can be precisely quantified by the dynamic angiogram. So now we can analyze every location here. We can estimate the proximal direction and distal direction, and you can calculate the takeoff angle, and using 180 minus the takeoff angle, you get the bending angle. So this can be analyzed with before PCI and after PCI using 2 projections, of course. And then it ends systolic phase and diastolic phase. Then we have 2 definitions here. One is the cardiac motion induced angle change, which is called delta C angle. And the other one is stent induced angle change, delta S. So this is a study that I also presented 2 years ago. So in this retrospective study, we analyzed about 101 patients with left main standing PCI with following two-stent technique. 30 of them have instant restenosis at the circumflex ostial in 1 year, defined by QCA diameter stenosis larger than 50%. And among all the parameters, we identified that the bending angle change due to the cardiac contraction, cardiac motion, is the strongest predictor. So if it's higher than 16 degrees, then you have a much higher event restenosis compared to if you have lower angle change there. And furthermore, we found out that there's no difference either whether you are using crush or clot or T-standing. So these are some new data. So in order to validate in a larger cohort, we still continue to analyze more data. So we want to analyze all the data, all the left main bifurcation PCI case from Fuway Hospital between January 2010 to December 2015. So 1,845 patients were screened, and in the end, we were able to analyze 776 patients. 200 is a two-stent strategy, and 571 is a one-stent strategy. And this is the preliminary result. So still ongoing because we want to analyze up to 1,000 patients. This is the current result before I came to here. As you can see, interestingly, in two-stent strategy, the dynamic change of the bending angle predict the 3 years bifurcation oriented composite endpoint, but not in the one-stent strategy. So this is something that is new in this finding. So ladies and gentlemen, simplified coronary wall strain can be performed solely from a single angiography view by characterizing the coronary deformation behavior in radial direction. High radial wall strain otherwise correlate with plaque vulnerability, where low radial wall strain is associated with good clinical outcome. And angiographic delayed bending angle change has critical prognostic implication for stent failure, especially for left main bifurcation PCI with two-stent strategy. A larger bending angle change over cardiac cycle larger than 16 degrees is associated with a significant increased risk of instant restenosis at circumflex ostial. And thank you very much for your attention.
Any questions for Dr. Tu or comments? I would like to ask you, can you speculate why in provisional bending does not have that impact as it has in two-stent strategies?
Yeah, I think that the circumflex, there was a very special anatomy there. So you have more change in the bending angle. Then if you put another stent there in the circumflex ostial, there are more compression on the stent
you
edge
restrict
there.
the motion.
Yeah, exactly. So that maybe is not good. So if you see there's a large change in the bending angle because during systolic and diastolic, and then that may be an indication that it might not be good to put two stents.
Yeah, fantastic. With that last one, we agree 100%. Dr. Magdi, can we have Mike?
Yes, sometimes after we finish the stenting and intervention, the angle is changing. We start with certain angle and then as if we straighten the artery or something. And so how do you figure this in your study?
Yeah. So in the previous study, I report also the change of the angle because of the stent. And it was also an independent predictor, but it's less stronger than the angle change because of cardiac contraction. So indeed, you put a stent there, and if you change the bending significantly, it's also an independent predictor for restenosis. That's what we observe.
Yeah, I remember publication from Prof. Seruius. Girazis was the first author. 3D angle calculation also showed.
Vessel diameter influence. The diameter of the vessel has any influence on this?
No, not in our analysis. Yeah. I think the bending. Before I think are using bifurcation 3D reconstruction, which is more complicated because you need to have two good view, and sometimes it's not possible. So we propose maybe bending is better to use the single vessel reconstruction. And also the advantage is that you can take into account the curvature at the bifurcation core, and that's probably also important as well.
Have you done any bench test on flexibility among different stent platforms?
Not bench study. We just analyze the.
Because there could be differences between stent platforms. How many longitudinal connectors do you have? So.
Yeah.
So we need a flexible stent, or maybe we can use it for the decision to do a drug-eluting balloon and not stent the circ. Thank you.
I completely agree with you. Maybe that's the area that we should try to use.
One thing that could be interesting to look at is vessel stiffness, like doing pulse pressure divided by stroke volume or something like that to estimate, because, I mean, we place stents without at all thinking about the vessel stiffness, and there could be both regions that are stiffer than others, and there could also be a lot more collagen involvement in the vessel wall that could be of interest to look at.
Yeah, definitely. But the bending, because cardiac contraction, the strength is probably higher than that.
As we saw the video before from Professor Nakamura, CT angio of the circumflex, it looks like I'm doing peripheral interventions, and it looks like the inguinal region of femoral artery. It's moving and bending. And maybe the idea of this osteal lesion of circumflex should be treated with some flexible stents that will be probably like Supera stent of Abbott, that will probably follow the movement of the circumflex. And I have a question for everybody, because I have several cases, I mean, more than 50 cases, DK crush, and we are doing now follow-up, but only angiographically guided. They're all, 85% are asymptomatics, but on site we see pinching or stenotic osteal circumflex. Should we treat this or not? Asymptomatics patient, yeah.
Yeah, if it's routine follow-up, if you see it, I think it's appropriate to do FFR and then evaluate if it's ischemic or not. I mean, if you have dilemma, location of the osteal circ is really something that needs to be tested. If this is, I don't know if somebody has different opinion. Okay, if not, thank you very much.
Thank you.
It's always brilliant. I'd like to invite Mattia Lunardi, fractal law of bifurcation, quantitative coronary angiography, to assess left main bifurcation. Mattia,
Thank you very much for your kind introduction, and I'm very pleased to be here presenting this data on behalf of all the investigators of the trial, which from we obtained this data. Indeed, we are talking about the Polbos left main trial that was put on hold because of the pandemic during the COVID and never resumed, so the enrollment stopped up to half of the patients, more or less, and we were able to use at least the diagnostic phase data to perform this analysis. So to understand why we perform this study, we have to revise something that maybe it's very clear to you, but anyway, we know that in the left main bifurcation, the plaque growth is more frequent in the lateral wall of the distal left main because of the low shear stress, and most of the time this involves also the daughter branches. Indeed, in this study that, I'm sorry that the image is a little bit blurry, but anyway, that it was already shown today, Oviedo some years ago demonstrated that the angiography assessment of the left main bifurcation is not actually reliable. Indeed, comparing that to HIBOS, we have an underestimation actually of the distribution of the plaque in the distal left main towards the branches. As you can see, 50% only of the lesion are classified as Medina 111 by visual assessment compared to the HIBOS evaluation of this lesion, where up to 62% of the patient presented a lesion involving both branches. So having said that, over time there have been different software to better analyze, better quantify the left main stenosis, starting from the single vessel QCA that of course was inappropriate for this kind of lesion because ignoring the natural anatomy of a bifurcation, followed by the development of dedicated bifurcation QCA software that better actually that were better in analyzing and quantifying the reference diameters of the vessels and therefore also of the stenosis. But some authors argued that maybe with the implementation of the fractal laws, such as the Finet law, we may also increase the accuracy, in particular in some specific setting of lesion like the diffuse disease of the left main. And so we should use these to derive the correct, the real reference diameter of the vessel and therefore the actual diameter stenosis. Having this in mind, we wanted to use this data to, first of all, understanding or better confirming that visual estimation is unreliable in this setting. And we wanted to evaluate if the bifurcation dedicated QCA is enough for determining, quantifying the lesion severity of a distal left main stenosis, or if we need to implement some fractal laws into this software, into these measurements, and eventually if we can also use this as a measurement that somehow has a predictive functional role. So the POLBOS trial, as I said, was on hold during the pandemic. This was a trial that was actually aiming at evaluating the performance of a dedicated bifurcation stent for, in this case, the left main, the BioSlim C. And the enrollment of this patient was based on the diagnostic angiogram, not any other kind of imaging. But it was, of course, left to operator discretion to send or not the patient to the core lab, but was the core lab decision, the core lab evaluation to assess the eligibility of this patient. Indeed, any patient underwent a dedicated bifurcation analysis, a standard dedicated bifurcation analysis of the distal left main lesion, plus the measurement, also the adjustment with the Finet law. And only after confirming that actually there was a significant lesion, meaning more than 50% in the either left main or LAD at least, so excluding the Medina 001, the patient could have been enrolled. This is an example of a typical patient. Actually, the angiogram was analyzed with a bifurcation dedicated QCA, with a segment analysis reporting the measurement of the lever of the left main, the LAD, the circumflex with the reference diameter and diameter stenosis. As you can see from this example, we got 51% stenosis at the level of left main. But after the adjustment with the implementation of the Finet law, actually the reference diameter of the left main changed to from 3.0 actually to 4.3, and therefore also the diameter stenosis amounted at 66%. In this case, the Medina didn't change actually, but we will see then the impact of this analysis. So according to the protocol, the most severe stenosis among the two methods, so the bifurcation dedicated QCA or the Finet-derived bifurcation dedicated QCA, was used for the eligibility of the patient and for the study purposes. And these are the other examples. So we found patients with equal measurement according to the bifurcation QCA without Finet and with Finet. and some patients that with FINE actually had a more severe stenosis, and some patients that with FINE had actually less severe stenosis. So why we selected the most severe stenosis between the two? Because actually there can be different scenarios. According to the plaque distribution in the distal left main, these are just two examples, but we can, of course, discuss about that. In the left panel, we can appreciate a diffuse disease of the left main, of the proximal main vessel. In this case, of course, the calculation, the reference diameter through a QCA is underestimating the correct reference diameter of the vessel, because we have just the lumen measurement that in a diffuse disease is not reflecting the real vessel dimension. So in this case, the application of the FINE law can actually, in presence of healthy distal ductal branches, help the operator or the analyst calculating the correct vessel diameter of the proximal main vessel. On the right side, we have the opposite example. We have a healthy proximal main vessel and maybe a diffuse disease in the ductal branches or an excessive tapering of the vessel. In this case, we expect that through the standard QCA, we are able to calculate a correct reference diameter of the proximal main vessel while using maybe the FINE law and using the reference diameter got from the QCA of the branches. We may underestimate the proximal vessel diameter. So that's why we selected the highest, the most severe stenosis between the two methods. So every patient, according to the protocol, had to have at least a proof of ischemia. And in its absence, of course, the operator was asked to perform a invasive functional assessment with IFR. IFR was checked by the core lab about the wear position, about the normalization, about the presence of tandem stenosis, and so on. And the lowest IFR, when the pressure wire was placed in both branches, were selected for study purposes. So our endpoints were basically the following, to answer to the previous question that I showed you. So the difference in Medina classification according to the visual assessment and the core lab report QCA, the difference between the FINE QCA and the Bifurcation QCA without the FINE law implementation, and finally the correlation between these two QCA methods with the IFR values. So these 84 patients were eventually included in this study, starting from 120 patients. The remaining didn't have a functional assessment, so were excluded from the present analysis. And among these 84 patients, the median diameter stenosis at the level of the left main, according to the Bifurcation QCA without FINE, was 52, with a reference diameter of 42. While implementing the FINE law, actually we got a slightly lower median diameter stenosis, 51% level of the left main, and with a reference diameter of 4.1. So according to IFR values, 72 patients, 86% actually presented an abnormal IFR, so meaning a positive ischemia test. And when we looked for the classification of the Medina according to the core lab reported QCA, so according to the highest percentage diameter stenosis, we got that the most frequent Medina was the 100 with 50% of cases, followed by the Medina 010 and the Medina 110. And the remaining cases that were very few actually involved also the circumflex with the exclusion, of course, of the Medina 001. So this is the comparison between the visual reported Medina by the operator and the core lab Medina based on a QCI assessment. Actually, we found that there was an agreement that was quite low, 64%, and in particular the visual assessment tended to overestimate the lesion in the distal left main with an higher frequency of Medina 111 in contrast with a reduction of Medina 100. Between the two methods, so the Bifurcation QCA without the FINE and with the FINE formula implemented, we got an agreement of 79%. The FINE, because of the lower actually diameter stenosis, median diameter stenosis, tended to downgrade some of this lesion from 100 to 000. Indeed, the eligibility rate would have been quite lower if using only the FINE-derived QCA. 90% of cases would have been enrolled instead of the 84 patients. And with the bifurcation QCA without the FINE low, the enrollment rate would have been more or less the same. That means that probably the distribution of the plaque was more the right panel, so where the QCA was giving us the correct reference diameter assessment. So regarding the correlation with the functional assessment, we found that actually the agreement with of the bifurcation QCI without the implementation of the FINET law was quite higher than the one with the FINET law. And in particular, I want to highlight that there were quite several patients presenting an abnormal IFR and non-significant stenosis according to the FINET-derived QCA. And these were basically all the patients that were reported having a Medina 000 according to the FINET law. So concluding, I think FINET law-derived bifurcation QCA not always improved the accuracy, but it depends actually, it's not true that maybe it is wrong or it's better, but it really depends on the pattern of the plaque and the distribution of the plaque at the level of the bifurcation. And the lower correlation with the functional evaluation may suggest that fractal laws are maybe more useful for vessel sizing than prediction of ischemia. So we can use them for better prediction of the vessel dimension in absence, of course, of intravascular imaging that would solve, of course, the situation. And the visual assessment should not be, of course, the only way that an operator chooses to diagnose and to assess the severity of a distal left main stenosis. Thank you very much.
Thank you very much. Any questions from the panel? Christian?
Yeah, yes, one thing you could do, because one questions, are there difference when you look at the BIF QCA compared to the FINED? One was 78% and one was 86%. And you could take it one step further and look at IDI, the discrimination index and net reclassification index to see how often you would actually change a decision using one method over the other.
Absolutely true. This is
There are other branching laws for coronary trees. You have the Murray's law, which is abandoned now. And after the FINAE, there is the UOCASAB. I don't know if Taylor and or Dr. Morris are there. UOCASAB is, they did a meta-analysis presented last year, telling that UOCASAB is the best branching law to describe the coronary tree. So maybe with branching, using the UOCASAB formula will be better, giving you better diameter, true diameter for the bifurcations, which is most important to choose the balloon and the stent you will put. So regarding the physiology, okay, I don't know, as you.
Thank you. See, yes, I think we will consider to also extrapolate this data with other fractal laws to see if there is a difference, and that could be a good follow-up of this work. We selected actually the FINA law because at that point of the time of the protocol design, of course, this study, there were some more data about the correlation of the FINA law and maybe the also functional assessment of these patients. So that was the reason why they implemented the FINA law compared to the other fractal laws.
Did you see any challenge? Sometimes it's difficult to see the circ ostium on angio, and if you have a high takeoff of the first obtuse marginal, how do you handle that?
Yeah, that's another very important point. So to evaluate, to perform this analysis, it was very important, mandatory, that the operator offer to the core lab a good angiography with the best view of the bifurcation angle without overlapping of other vessels and other branches, because otherwise it would be impossible to rely on this.
Sometimes it's impossible.
It's impossible, yeah, of course, and they did the best.
Yeah, extending to this question, also those with the very short left main. So, is there any bias in? I mean, how can you adjust your intervention and the imaging if the left main is very short? Even the orifice of the CX and the LAD are very close to each other, and the left main is very short.
So, if the analysis was not feasible, or the angiography was not accurate, or because the anatomy was such, like in this case, the patient wouldn't have been enrolled, because we had to have the confirmation by the core lab of this kind of analysis showing at least a 50% stenosis in the left main or the LAD. So if it wasn't analyzable because of this, this was not a good patient to be enrolled in this trial.
Other comments? Okay.
Thank you very much.
Thank you very much.
Thanks.
Then let's have Professor Shin to talk about the use of drug-eluting balloons in true bifurcations in the left main.
Thank you, Chairman. And my topic is the DCB-based treatment of left main true bifurcation region. And I'm very sleepy, but my topic is very provocative. So this is my disclosure. And so with the proper region preparation, and even left main can be treated with the DCB alone. In this case, and at 6 months, the vessel stayed open without restenosis, showing durable healing without a stent. So the left main stem and true bifurcation and even left main CTO region is quite well treated after optimal region preparation. It's real. And a key advantage of DCB is that it avoids carina shift. As a result, DCB preserves side branch patency without compromising flow. So its main advantage of DCB treatment for bifurcation region. In left main bifurcation, DCB and DS can be combined in so different ways, and DS plus DS, and DS plus balloon angioplasty, and DS plus DCB, and sometimes in DCB only approach. So recently, a study from China evaluated an DCB application in left main de novo true bifurcation region. Patients in the hybrid group experienced fewer adverse events. There is mainly derived by the target lesion revascularization. However, and caution is warranted in interpreting this study because both the main vessel and side branch were pre-dilated with balloon angioplasty, and in the drug-eluting stent group, and 43% of side branch were treated with the balloon angioplasty alone. It's not applied the anti-proliferative drug. So the comparison is essentially reflects balloon angioplasty versus drug-coated balloon for the side branch. So therefore, it is not surprising that lay lumen loss of the side branch were higher in the drug-eluting stent group, which likely contributed the main driver of target lesion failure. And this is another paper. In the left main disease, the quality of region preparation makes a huge difference. And so when preparation was good, the TLR risk at 2 years was only 2%, but when preparation was poor, target lesion revascularization exceeded 21%. It's 10 times then. This clearly shows that optimal lesion preparation is the key to successful DCB treatment in left main disease. So I'd like to share our data comparing DCB-based treatment in left main true bifurcation lesion with matched cases from the COBIS-3 registry. That is an DES-based PCI registry for bifurcation lesion. So we studied the 39 left main true bifurcation patients treated with a DCB-based strategy and compared them with 39 one-to-one matched patients treated with a two-stent strategy from COBIS-3 registry. The primary endpoint was 2-year major adverse cardiovascular event, including death, target vessel MI, and target lesion thrombosis and target lesion revascularization. And we strictly matched based on demographic risk factor, prior history, ISR, renal disease, and clinical presentation status, and disease severity. So in this study, in the drug-eluting stent only group, all patients had been treated with a two-stent technique. However, in contrast, the DCB group showed more diverse strategy. 38% were treated with the DS plus DCB, and 18% with the DCB plus DCB, 5% with the DCB plus balloon angioplasty, and 38% with the DCB alone in main vessel without any additional device for side branches, circumflex artery. The two groups were well balanced at baseline with no major difference in demographic or risk factors. However, only one exception was in-stent restenosis, which was more frequent in the DCB group. This is a summarized region and procedural characteristics. The DCB group included a higher proportion of Medina 111 region, and more than half of DCB group were managed with the DCB alone. And device and utilization also quite differed. The DCB group used more balloons. However, the DES group required a higher number of stents with a longer total stent length, and overall patients in the DCB group received the fewer and shorter stent compared with the DES group. So, and DCB-based PCI markedly reduced the stent use, highlighting its stent sparing effect. So looking at clinical outcome, results were comparable between two groups. In the DCB group, only 5 patients experienced MACE. 2 target lesion revascularization were related to in-stent restenosis lesion. One occurred due to discontinuation of dual antiplatelet therapy. He is quite poor drug compliance patients, and 2 were associated with suboptimal balloon angioplasty in left main and LAD ostial lesion. Ostial lesion is quite difficult to make the optimal lesion preparation. Importantly, there were no cardiac deaths in both groups, and only 1 myocardial infarction occurred in the DES group. So over 2 years, MACE rates were comparable between two groups. And this is a 65-year-old man with unstable angina. We can see focal tight stenosis in the middle artery, as well as an diffuse and disease involving the left main bifurcation, LAD, LCX with multiple, some calcified region. The LAD shows reduced flow and diffuse severe stenosis. So I recommend coronary artery bypass grafting, but he strongly refused. In Korea, it's a usual finding. And so according to insurance regulation of Korea, we only used only 2 pre-dilation balloon. So I selected 2.5 millimeter and 3.0 millimeter non-compliant balloon. With this, I performed extensive angioplasty of the left main, RAD, and LCX with a high pressure. The LCX was treated with 3 and DCB, paclitaxel coated balloon, and after that, and left main proximal RAD was stented with a 3.5 millimeter drug-eluting stent, and finally the middle RAD was treated with a 2.5 millimeter drug-coated balloon, also and paclitaxel coated balloon. The patient returned 26 months later with atypical chest pain. There is finally diagnosed was a gastritis. However, I just recommend a coronary angiogram to rule out the ischemic event. Compared with the baseline, the vessels were enlarged and overall flow had much improved. The flow in the RAD also improved like this. In the spider view, the left coronary system shows marked improvement. The left main bifurcation is also in quite favorable finding. So with good lesion preparation is everything, and left main is no exception. Even complex left main trifurcation CTO lesion can be successfully treated using DCB only. In this case, I also treated with 3 DCB in the left main trifurcation CTO lesion. So this is a take-home message in unprotective left main true bifurcation. DCB-based treatment was feasible and achieved outcome comparable to conventional drug-eluting stent PCI. And DCB simplifies the procedure by avoiding and complex two-stent technique without increasing ischemic risk. However, we need an RCT to validate these results and define the role of DCB in left main bifurcation disease. Thank you.
Congratulations, it's really phenomenal. Can I just ask, what was the population that was treated just left main LAD without any intervention in the circ? Was it completely healthy ostium of the circ or small circ? How you selected? 38% had only crossover balloon.
I usually use the functional test for the small circumflex artery. So, but the circumflex artery is very large size and over 3.0, 3.5, and I just use touch the circumflex lesion. However, in the small vessel, it's just a functional assessment. There is usually just a very high level of QFR or FFR. So I just crossover.
It's huge, 40%. Marek.
Congratulations. Just a question. After such case, how long people or patient are staying in the hospital? Just one night or 2 nights?
Yeah, just 1 night.
Just 1 night.
Yes.
And DAPT is according to clinical presentation or 1 month for all?
Yes, and for left main?
Yes.
There is no any evidence about the duration of depth after DCB treatment, so I just usually follow the guideline of the drug-eluting stent treatment. So however, the duration is getting decreased now. So, and stable angina, and I just use the duration is around 3 months, but coronary syndrome patients, I just wanted them more longer
Sure.
Yeah.
So according to clinical presentation and like
year.
for the
Yeah, right.
Yeah, thank you. Other questions, Dr. Magdi?
So the characteristics of the lesions for whom DCB were used, I understand that this should be not highly calcific, so that it should deal with dilatation. I mean, you need proper preparation before, which is most important. The other thing, if you had done this to acute coronary syndrome, there had been some thrombus-containing lesions or not?
Yes, and for the left main disease and also for the large vessel PCI, and I usually use the intravascular imaging. So and if there is a huge amount of thrombosis there in the acute coronary syndrome, I just first of all I just want to remove the thrombus first, and then reassess the region. So usually it's very difficult to remove the thrombus. And also there is a significant residual stenosis with a large amount of thrombus there, and I just treated with a stent.
Can I ask also for 40% of DES in left main and DCB in the circ, is it individualized or you have the rule which one comes first, DCB in the circ, then stenting, or the opposite?
It depends on the patients and situation. However, and usually I just treated the kind of procedure for the large vessel, the main vessel, and I just want to treat the more completely. So usually I use the stent, but circumflex is almost I just treated with DCB.
But you treat circumflex after left main stenting or before?
Circumflex first.
First circumflex.
Yeah, always
okay.
first.
Just because of our debate. If there are no further questions, congratulations. It's really stimulating. And the last presentation of this year EBC meeting, Dr. Choi has the privilege to close with his presentation, please.
Okay, thank you for the kind introduction, Mr. Chairman. Good evening, ladies and gentlemen. My name is Kyung-Che from Samsung Medical Center, Korea. I'm very honored to give this talk as a part of final session's final lecture in the EBC 2025. My talk is about the benefit of intravascular imaging guidance for left main bifurcation lesion. The PCI for left main bifurcation lesions are the most challenging procedure in the field of interventional cardiology because of the unique anatomy of a bifurcation lesion. First, there is often big size discrepancy between proximal and distal main vessel, and carina position and bifurcation angle can also vary widely, and distribution of characteristics of atherosclerotic plaque are heterogeneous. More importantly, unlike non-left main bifurcation lesion, almost all side branches of left main bifurcation supplied large territory. Here is some case example for left main bifurcation PCI. With intravascular imaging, we can assess the lesion characteristics before PCI, and we can select the proper stent size, length, as well as NC balloon size for POT, and we can detect the peri-procedural complication during PCI, and we finally optimize the stent with expansion and apposition. In last year, the October trial published in New England Journal of Medicine 2024, this study is to examine examine whether routine use of OCT during PCI of complex bifurcation lesions improved clinical outcomes compared to standard practice with angiography-guided PCI. The primary endpoint of the October trial was MACE, a composite of cardiac death, target vessel MI, or target lesion revascularization. And this study clearly shows that the OCT-guided PCI reduced the risk of major adverse cardiac events compared with angiographic-guided PCI, regardless of lesion location or stenting technology. 2 years ago, we also published the Renovate Complex PCI in New England Journal of Medicine. This study included 1,600 patients with complex coronary lesion underwent PCI, and 2-to-1 randomization was performed to either intravascular imaging-guided PCI versus angiography-guided PCI. I think the most unique feature of the Renovate Complex PCI trial is the selection of imaging device. IVUS or OCT was left to operator's decision based on the patient or lesion characteristics. The primary endpoint of Renovate Complex PCI was target vessel failure, a composite of cardiac death, target vessel-related MI, or clinical-driven target vessel revascularization. Among patients with complex coronary artery lesion, intravascular imaging-guided PCI lead to a lower risk of target vessel failure compared with angiography-guided PCI, and this result is consistent after excluding periprocedural MI as a clinical endpoint. After publishing the Renovate Complex PCI, we performed the pre-specified subgroup analysis for left main lesion. Approximately 200 patients had left main disease. About half of them had distal left main true bifurcation lesion. In terms of the stent strategy, simple crossover with or without final kissing ballooning was mainstay, but 13% of patients received two stenting strategies, and the most common used strategy was crush. Here are the results. The intravascular imaging-guided PCI was superior to angiography-guided PCI in reducing the risk of target vessel failure with or without procedure-related myocardial infarction. Surprisingly, the hazard ratio was only 0.31. When we performed the meta-analysis of 18 trials in comparison with imaging versus angiography guidance in left main PCI, intravascular imaging-guided PCI was also associated with a lower risk of all-cause mortality as well as cardiovascular mortality compared with angiography-guided PCI. In this regard, 2024 ESH guideline for CCS have changed the recommendation grade for intravascular imaging-guided guidance by IVUS or OCT on complex lesions, in particular left mainstem or true bifurcation lesions. I'd like to introduce another papers regarding the association between operator experience with IVUS guidance and clinical outcomes in complex PCI. This, before I talk, I declare my independent lifetime experience with PCI was 5 years, so I'm still a less experienced operator. This study was a single center retrospective registry enrolled 6,000 patients who underwent PCI with complex PCI with DES. And firstly, we stratified according to patient, according to operator experience, and then we compared the outcomes between IVUS versus angiography guidance. Surprisingly, compared with less experienced operator tend to more use of intravascular imaging when performing the complex PCI. This figure shows the operator experience and outcomes. And when patients who were treated by inexperienced operators had a significantly lower risk of cardiac death or target vessel MI than those who were treated by less experienced operators. As you can see, the spline curve as panel B, there was clearly invert association between operator experience and risk of cardiac death or target vessel MI. When we compare the clinical outcomes between IVUS versus angiographic guidance, although IVUS-guided PCI was associated with improved outcomes in both experienced and less experienced operators, but beneficial effect of IVUS was more prominent for less experienced operators. More importantly, the greatest benefit of intravascular imaging guidance was observed in left main disease, regardless of operator experience. So this is my conclusions and summary. The RENOVATE complex PCI and October trial support the beneficial effect of intravascular imaging-guided PCI for complex lesions, including bifurcation or left main coronary artery disease. Especially for left main bifurcation lesion, use of intravascular imaging should be considered as an essential tool to improve patient prognosis, even among experienced or high-volume operators, and the beneficial effect of intravascular imaging were more prominent when complex PCI was performed by less experienced operators like me, and therefore systemic education should be provided so that beginners can familiarize themselves with the use of intravascular imaging when faced with the complex coronary regions. Thank you for your attention.
Thank you very much. I think it's very interesting results. Do you think the impact of doing a trial is where you are doing the trial? If you do a trial where you randomize to angiographic guidance in a country that has a penetration above 90% for intravascular imaging, or you do a trial in France that have a penetration of 3% and can be randomized to imaging, do you think it matters where you do a trial for the difference in outcome between angio and imaging?
Yeah, thank you for your great comment. But in Korea, not 90% imaging was used. In Korea, I think 20 to 30% of patients received intravascular imaging-guided PCI, unlike Japan. But I think imaging experience is very important to improve clinical outcomes because but in the less experienced operators, imaging benefits is more prominent. So I think if an operator is less experienced, we should use intravascular imaging. So I think another country, Western country, should use intravascular imaging even though they have less experience for imaging use.
Thank you very much. Other comments or questions?
Can I just comment? There was a recent publication from British Cardiac Intervention Society, and actually they found almost exactly the same as you, that use of imaging was higher amongst experienced operators, but benefit was equally distributed, even higher in less experienced operators. So even in country with much lower percentage of IVUS guidance or for left main, although there was clear mortality benefit, they show that if you're experienced, you use more imaging to get even better result. If there are no further questions, thank you so much.
Thank you very much.
Thank you, Evald. Thank you all. So I would like to invite our president, Jens, to close the meeting.
Thank you very much, Goran. May I have my slides? The meeting has come to end, the scientific part of the meeting. And these are the final remarks, as we always have. But first of all, thank you for all your support, your encouragement, your engagements in our discussion. This is actually what makes the basement for all the recommendations, all the view of procedures that we can have together. This is this one yearly meeting where we gathered, go through the literature, discuss, have important input from different places of the world, but focus on bifurcation treatment for a higher good. So thank you, all of you, very, very much for all your engagement and for the participating in these two very, very compact days. Thank you, of course, also to the sponsors, which makes it possible for us to be here. And thank you also very much to Alexandra and Ben from Medi 8 Event, who actually takes care of all the organization. As you can see, it's always very, very dangerous to give me a microphone. So thank you for the applause, but I'm definitely not finalized yet. The final remarks, you can see this was the picture. It's actually sprit new, as you know, and you can see this was the backup this year. It has been an extremely well-visited meeting this year. We had actually some decline over COVID, and we have also made some changes in the board, and I would actually like and take this opportunity to share it with you, because it's pretty important for all of us for the future. But first of all, I will actually pay attention to Evald, which on the board meeting, during this meeting was elected as, well, we had a little problem with defining the title, so it became actually very long, but his Honorable Emeritus, President Emeritus. So, which is a lifelong position. And it's actually the creator, the founder, one of the main founders of the club, who stay with us all he like and all he will and all he can. And we are so happy to have you, Eve. So this was the first thing. The next thing is actually, we also have some who had retired from the board. We had said goodbye to Thierry and Olivier, and they have, of course, have to have replacements. But we have also reorganized, and that is actually a thing that is very different from all the other meetings. I'm very proud of being the new president, but I'm also very, very humble. So my first thing to do in official statements is actually to thank Goran. Goran, who took over in a very critical time for the club and bear with diplomacy, huge international network, hardworking, and an extreme knowledge within this field, kept us and pushed us forward on the basis what Thierry, Olivier, and Yves originally created. And of course, all the other board members, but Goran especially. Thank you so much, my friend. And as you all will realize, he's the past president. But have you seen his activities during this meeting? He's, for me, not at all past. He's extremely present. And thank you for that, Goran. Thank you. And that actually brings me back. That brings me back again to how do this club actually works. We work as a team. We survive as a team. But we are, of course, the board bear a lot of the work, and the executive board take a lot of the responsibility. But we survive as a team with a flat structure. And that's extremely important. But we only survive because of you. The network and all the input we got from every part of the world. So thank you very much for that. And most of the board you know, but there are new members. And you'll see some really new changes in the composition of the board. So, of course, I'm very, very happy to welcome Soledad Ojeda as one of the new board members. But also extremely happy and thrilled to be able to welcome Bong Kong Kwo, which from the very beginning and maybe long before that have been such an integrated part of the community. I've always supported. So it's actually to
have a lifelong love and finally get married. So welcome very much. And the next thing is the third member we have included this year. This is Carlos Colette, and he has been connected remotely. But Carlos has a long-lasting collaboration with the club over all the years. But he is also one of the gates to the future in imaging and in CT. So one of the things that is the new emerging things, like the DCBs, which will be the next chapter. So again, also very welcome to Carlos Colette. As you can see, one thing more, we have actually also elected Manuel Pan as secretary. And this is again how we try to build a flat structure, but also keep the memory in the club. So this is the next step we have done. All these things is done for a purpose. And there's one thing that I really want to state in front of all of you. We have been working with bifurcation now for 21 years. And it has been an extremely successful journey for many reasons. And every year we are thinking, okay, are we about to close the topic? But the answer is no. There's always a new thing to discuss. And our consensus reports have been showing us these evolution of knowledge that actually increase because of the discussion we have here today and in the other meetings. And it's really important to focus on these things forward because we have so much to do. We have so much to do. The focus this year has been the circumflex ostium. And it might sound a little bit peculiar, but it's actually the essence of everything we are doing in bifurcation. All the tools we have, imaging, techniques, complications, whatever, everything amalgamated down to the ostium of the circumflex. So the next consensus we will work on will be how do we address the ostium circumflex, because with that, we actually give the state of the art of the position we are. And with that said, next slide. I'll just say thank you to all of you and see you again next year. And the gala dinner. The bus will leave from the foyer at 7:45. So if you need to brush your teeth and have a new shirt, run for it.